in terms of strictly chemotherapy, oftentimes, especially when they've got these scenarios like fistulas, the rates of infectious complications and so forth really skyrocket. How about plasmacytoid?
Yeah, really difficult one, and I think we're really lacking data. I think they do respond, just personal experience. I think they do respond to cisplatin-based chemotherapy. The tumors do shrink, and I've had a few PT0s. The very unfortunate thing is that despite having a PT0 and what seems to be a success, because it metastasizes or spreads so quickly, and goes throughout the peritoneum, those patients are still at very high risk of developing peritoneal carcinomatosis later. So my answer is still yes on the chemo. I try to move forward unless I have a PT1. Obviously, I try to get those patients as soon as possible. But I think they do respond. We certainly need more data. I think we need to sort of pool our efforts together. Plasmacytoids behave very differently than all the other variants in urothelial carcinoma. So we need more data there.
Yeah, I think it's probably kind of implicit for these variant histologies. Worthwhile having your GU pathologist take a look just to make sure we kind of know what we're dealing with. And then I would wholeheartedly agree that plasmacytoids certainly catch my attention in a big way and can also be some of the nastiest cases if you actually make a cystectomy with that kind of pagetoid spread into the peritoneum, and things can be quite fixed. In some of those scenarios, though, shockingly, you're like, oh my gosh, this is really bad. And then, sure enough, they're a pathological T0, as you kind of mentioned. Well, I I kind of like, not to oversimplify, but for the sake of time, perhaps, if it's urothelial with some degree of variant differentiation, still stay fairly aggressive with chemotherapy, squamous and adenos being kind of the outliers. If they're pure squamous, pure adeno, it is case by case, as you mentioned, but those are ones where I feel like, moving straight forward to definitive therapy makes more sense. And does variant histology impact your counseling for surgery versus radiation?
Yeah, great question. And I think most of the data, as you know, stems from in the radiation experience stems from pure urothelial or minor variant histology. Having said that, there is a European Urology article that does include some of the variant histologies, and it seems to be effective. The radiation seems to be effective in those settings as well, but the numbers are very small. I remember discussing this with our radiation oncologist. Said, "Oh yeah, it works in nested variant." And I said, "Well, look at this table. There's one nested variant published in the entire literature here. We can't make determinations." So uh, yet to be seen. I think they're probably not ideally suited for radiation because of lack of data. These cases are rare, but what really impacts my decision is having variant histology in high grade T1, even if it's re-resected. Certainly, that's a marker of upstaging. It's a marker of biology of the tumor to begin with. And so I'm very wary doing conservative treatment for patients with high grade T1 and variant histology.